All right, well, I'll go ahead and get started. If you can move to the next slide. Here are our partners, and thank you all for joining us. It looks like a number of people are calling in right as we're talking. If we can go to the next slide, here's our agenda for today. I'm going to share a brief literature moment. There was just an article published July 8th that provides new information for us that's relevant to what we're doing with the Pathways project. Then we just conducted a very nice two-day on-site consultation with the 3 Rogerson dialysis centers that are participating in the Pathways project, and Glenda is going to report on that. We're going to do a check-in with you and find out what are your successes. I know Steve Weiss from Atlantic has one particularly nice success to report. What are you learning? What have your challenges been? Glenda's going to talk about small tests of change. One of the things that we clearly learned, I'm chuckling a little bit, one of the things that we learned from our visit to Rogerson was that really the data collection in the beginning was pretty overwhelming. And fortunately, they feel like they've got that now under better control, but we don't want to overwhelm you with the next thing. So Glenda's going to talk about small tests of change. And then Dale has some great data to review with you based on the reports that you've sent back to us after the first full month of baseline data collection in May. And certainly at any point we'll be interested in your comments and your questions. But why don't we go to the brief literature moment? If you can advance, Sherry. Okay, so this just appeared July 8th in JAMA Internal Medicine. It was a study of just under 1,000 hemodialysis patients, and it asked them how long they thought patients of their age with similar diagnoses had to live. And the first row, if you will, of the different colors is what the patients themselves reported as their prognostic expectations. And you'll notice that only 11% of the patients thought that a similarly aged dialysis patient would have less than 5 years to live. The vast majority, as you can see, thought that hemodialysis patients live more than 10 years. Now, on the row beneath that one, with the long bar that's colored less than 5 years, is what the USRDS, United States Renal Data System, actually shows is the survival for dialysis patients. And 60% of dialysis patients in this country die within 5 years of starting dialysis. The bottom row there is the survival for transplant patients. So it's hemodialysis patients who go on to receive a transplant. And you'll notice, if you compare the top row to the bottom row, that current dialysis patients, their prognostic expectations are much closer to those of patients who would have had a transplant. So they really don't have a good knowledge of their prognosis. So let's go to the next slide. Whoops. Okay, so what the authors concluded was that their findings argued for more attention to communication around prognosis and nephrology training and continuing education programs and stronger efforts, I might put on our part as nephrology clinicians, to stronger efforts to cultivate prognostic awareness and manage prognostic uncertainty among patients receiving dialysis. So what Ann O'Hare, and she's a geriatric nephrologist at the University of Washington in Seattle, what she and her group concluded was patients are really quite optimistic about their prognosis, or else 40% of them were uncertain about their prognosis. And what they also found is the more optimistic they were, the less likely they were to have engaged in advanced care planning, the less likely they were to have had goals of care conversations or to have completed advanced directives. And the more likely they were to state that their preference would be to be on a breathing machine to receive aggressive life-extending treatments, because they really were much more optimistic about how well they were going to do than really was realistic. So the take home for us is, and we sort of knew this already, we have work to do in terms of educating our patients, not to throw, give them a cold shower, but we have work to do to educate them so that they understand that, especially the seriously ill patients that you're identifying with us with the Pathways Project, that these people really will need to make decisions because this is in their future. And to the extent that they do these things, they're more likely to get the care they would want. So large educational component to patients and their families, their loved ones, obviously in a very kind way, saying we want to be able to respect your wishes. All right, next slide. All right, Glenda, you're taking this part.
Thank you, Woody. Hi, everybody. So glad to have you join us today. And I want to start out by saying a great big thank you to the Rogerson sites, Manhattan East, Woodside, and Auburndale, who welcomed us to their centers on Monday and Tuesday of this week. We really enjoyed it and found it really encouraging and helpful for us as the Pathways team to get to see the sites and meet people and get to be engaged in how excited and engaged people are in the project. So thanks a lot to all of you. It took a lot of time from everyone's busy days, and we know that, and we really appreciate it. So what we really found that all the teams were highly engaged in the project. We have, as Woody has already said, found out that the data collection in this beginning phase is challenging. But it's been successful, and we'll hear a little bit more, some meaningful information out of that from Dale before the end of the call.
Sure. Glenda, if I could just add, if people are not speaking at this point, if they could put their phones on mute because we are getting some background noise.
Thank you. So Dr. Moss reviewed the Ask, Tell, Ask approach for Goals of Care conversations, and the team had made up some pocket cards for Goals of Care conversations, and we'll be sending some of those to your sites as well. Thought they were well received, and we welcome Rogerson's comments on this. And Dr. Moss also interviewed some patients with Dr. Berman and Hillary Marion, the social worker, and did some Goals of Care conversations, and also did capacity assessment. And I think everyone found that really helpful and illuminating. We found multiple possibilities for small tests of change as we talked through how the project will roll out and what the challenges are and what may need to change in our processes of care to be able to achieve our aim. One of them was just about where do you have the conversations? Terrified, not everyone's comfortable with that, but it was successful when we were there in Manhattan East on Monday with Woody and Dr. Berman and Hillary Marion. Another thing we saw at the Woodside unit was a very nice glassed-in isolation room that is not occupied by an hepatitis B positive patient at the time, and so we talked about, well, that could be used for a place to have a private conversation. And also we talked and touched quite a bit on the opportunity that telehealth may offer us in proceeding to have conversations and including family members that are distant or unable to come to the facility, and even perhaps with consulting with palliative care teams. So we're excited about this and looking forward to some small tests of change going forward with this. One thing was doing more MOLS forms, especially on the very seriously ill patients, and finding a way to get them into the hospital system so that when the patient is hospitalized, it can come into the chart and be honored, honoring the patient's wishes. Building relationship for home palliative care consultation service, and especially in Woodside and Queens, they're very interested in pursuing this, and the Pathways team are going to support them and work with them, and we're going to try to develop a pilot hospice program, finding a partner there in Queens. Finally, we were excited to hear that there's some spread going on in our project, and Rogerson Woodside is planning their own lobby day, and that was triggered by the Atlantic example last month. So thanks so much. finally, I'd just like to invite the Rogerson team's observations. I know Barbara from Woodside said she would be able to say a few words, and Dr. Berman, are you on the call?
I am, yeah. Can you hear me?
Hi. Yes, we can. Thanks. What would you like to share with us about the visit, or share with the others, really, the other participants?
Well, I mean, I thought it went well. I think, initially the biggest hurdle that we've had was in data collection. I think, we've gotten hopefully past the more difficult points with that, and now it's just a question of trying to, we found Dr. Moss to be very helpful in sort of going through, again, dialysis-specific discussion techniques. I think this is certainly, I think getting most forms on all of our seriously ill patients is something that we're going to try to do. And I think it's doable. I think, and that would be a nice outcome for us.
Great. Super. Thank you so much. Part of, we had a luncheon, and we had 6 physicians from Manhattan East that attended that and stayed the better part of an hour, most of them, and we were very excited about that. Also, Dr. Frumkin, the medical director of Woodside and Auburndale, attended the luncheon on the second day. So we're really very happy to have that much quality time with the teams that were engaged, including physicians. Well, thank you, Dr. Berman. Woody, would you like to add anything?
Yeah, no, so I'm wondering, I see Hillary and it looks like Barbara are on the call too. I wonder if they would like to add anything.
Can you hear me?
Yes.
Yeah.
Oh, okay, because my
Hi, Barbara.
thing's weird. Hi. We liked it because it was kind of a brainstorming session, and you kind of hit on most of the stuff that we were surprised with the concept of using the isolation room to interview patients, which is actually an excellent idea, because that room is not in use. The other thing with us was that our social workers are very excited to be involved in this, and we already have informal meetings as issues arise with patients, but they were very much in favor of formalizing those meetings so that on a weekly basis we can just touch base for 15 minutes or so and discuss patients that have come into the system and issues that have arisen with patients. So that seemed pretty good. Everybody seems to be on board.
Yeah, I thought it was wonderful to bring the social workers in. They were very engaged and interested, and I felt like they were being validated in some way as well by being included in the team.
Yeah. I think I'm seeing Hillary. Hillary is the social worker we mentioned who was with us on some patient interviews at East Manhattan. Are you on the line, Hillary? What would you want to add?
Yes, I am. Hi, how is everyone?
Hi.
No, I found the day to be very helpful. I particularly enjoyed doing the cognitive exam with one of my patients. I was actually quite surprised with how intact his cognition actually is, because I've understood from previous exams with neurology, he did not, the exact same test we had done, a lot of that was not answered well. So for whatever reason, maybe it was a better day for him. He did pretty well on it, and it was my first time actually stepping in and watching that. Both of the patients, I thought it was interesting, or maybe not so interesting, but they remained very consistent from other conversations I've had with them before. So I don't think there were like major sharp revelations, but maybe just a more concise conversation about all of it. It was interesting seeing, like Dr. Moss, how he explained the different interventions and what that could mean. And I think our patients were able to think maybe for the first time about CPR. That was definitely something new for some of our patients, which maybe that's bad on our part, but they both, or that one patient particularly, seemed to not even really know what it entailed. And I think that did help. It didn't change what I think her overall wishes were, because I think she always wanted eventually to not have dramatic measures taken, but I don't know if she would have put CPR in that same dramatic place without it being spelled out the way that it was. And I thought you did a really good job of explaining it, but also for her to fully understand what that would mean for her. And that's not in line with what her wishes would be. And
Yeah.
both of those patients, I think I did advanced care planning notes for both of them. And both are interested in another meeting for a MOLST. So we are going to start to implement them more. I think Dr. Berman would be proud. He's on the call. He did one today. So.
Good. Yeah. And Hillary and Dr. Berman, the other interesting thing is that it didn't take that long. You know, you can have a decent conversation in 15 minutes. So people think, where am I going to get an hour to talk to, you know, each of these patients? It doesn't necessarily need to take that long.
No, it didn't.
Yeah, I mean, I think especially the patients that we spoke with you, we'd already started the conversations. I think sort of introducing yourself, it seems like a better use rather than blocking an hour, starting the conversation, saying we'll come back and sort of talk about it some more seems to be the most efficient, in my very limited experience, seems to be the most efficient way to do it.
And that's right. It's a process.
It allows the patient to take it in and have some time to consider it. And yes, like what he said, it's a process, absolutely. Lynn, we saw you're on the phone. Would you like to make some comments?
Sure, yeah. No, I really enjoyed the meeting. You know, again, you kind of already touched based on a lot of things that we talked about. But, you know, it was a nice, you know, collaboration between, you know, all of our facilities together. And it was kind of nice to see that, you know, we're all kind of on the same page. You know, I felt like we were a little bit behind, but, you know, a lot of people had the same concerns. And, you know, just reassuring that, you know, we have the support from our team and also, you know, the entire Pathways project team. And other than that, it was also nice because, you know, I initially was the only one that came from my facility, but on Tuesday when we had that meeting, you know, we had our social worker, we had the medical director, and even today we have our dietitian joining on the call. So, yeah.
We're all here.
Yeah, we're all here. So,
great. Hi, everybody.
Yeah, hi. And I just wanted to reinforce one observation. This is Dale. That I think one of the things that impressed us, and that you guys yourselves commented on, is you're actually really doing a lot of these things already. But there was a way that we talked about systematizing it or formalizing it, so you make sure that it does get to everyone and people don't fall through the cracks. But that kind of, as we went through that sort of brainstorming of what changes do you want to make, there was really already a lot in place you could build on. And I had the sense you came away feeling maybe a little more encouraged. Like it's not all new stuff you've never done before, but it's more a sense of building on what you do and integrating it into things that are in place. Is that a good summary?
Yeah, definitely.
Mm-hmm. Mm-hmm. Yeah.
Great. Okay.
Well, we came away really encouraged and excited.
Yeah. I just wonder, I see Dr. Frumkin sitting in the back. Did she want to add anything to the discussion? Because she was a very active participant.
She was. I'm sorry. I didn't know you were there, Dr. Frumkin.
I am. Yeah, so I actually found it very encouraging, and it did really solidify things that we were doing, and it really helps us to put this in perspective and to make sure that the program is really a solid program where no one falls through the cracks. And I'm also really looking forward to try to make those community connections so that we can really expand on the kind of help that we feel that we can offer our patients aside from just what we do in the dialysis unit. I'm really hoping to build those bridges with the community, our community palliative care support team, and see if we can really make this a bigger program.
Wonderful.
Right. You know, Dr. Frumkin just picked up on an important thing that we came back and have been discussing, how we can also help the dialysis center teams collaborate. And so we happen to know the director of palliative care at the hospital near the Woodside and Auburndale unit. So we're going to reach out to her too, Dr. Cynthia Pan, and just see what we might be able to do to at least get her to spend part of her limited energy trying to help the dialysis centers in the Pathways Project and looking at it as a way to develop an innovation that then might be able to be attempted other places as well. So we're hoping we can interest her that way.
I would hope so. It sounds like that would really be an excellent partnership.
great.
Well, so this has just been so great. Thank you all for sharing, and I hope that it piques your interest for those of you at the other sites, and we look forward to coming to visit you soon. So let's move on to the next slide. Thank you. So speaking of that, who wants to be next for a visit from our Pathways team? We have reached out to the ARA Denver units through Dr. Essen to talk about that. If you'd like to start setting up a visit from us, just email Peyton Smith, who's our new assistant, and we're very, very happy to have him join the Pathways team. Possible activities, and by the way, we provide lunch and or dinner for your team, the center staff. Everybody is welcome. Dr. Moss, as we've already described, meets with nephrologists to discuss conversation symptom management and also can conduct goals of care conversations with a patient, demonstrate doing assessment of capacity. I would be helping with team structure and small tests of change. And Dale is just good at everything, and she's especially good about talking about what the data is telling us and being just really and generally a very good person that synthesizes the information and sums it up very well. Discussing barriers, challenges, opportunities, and brainstorm approaches, and I think someone did mention from the Rogerson that it was sort of a brainstorming session, and we really love that and want to build on that to be a support to your team. So email and let us know. Next slide, please. All right, so now we're to our monthly site check-in. We've had a big one, really, with talking about our site visit, and we've heard from all three of the Rogerson facilities. We wonder what other learnings anyone is having. We want to open it up and see what anyone would like to share with your colleagues. Remember, all teach, all learn. We're all in this together.
Hi, this is Mary Beth from Dallas, the CKD.
Hi, Mary Beth.
Hey. This is not earth-shattering. We're behind the ball a little bit with getting legal approval, but we've moved forward on that. But one of the things that I couldn't relate last time was our death review. We looked at a subset of CKD 5 patients at one of our clinics where we're going to try to do more small tests of change. And there were 19 patients that had died within the last 15 months prior to the review, and none of them had on file with us advanced directives or advanced care planning discussions. And so that really kind of got people's attention, and I think that was valuable. And so we have a chronic care management pilot running there, and we're going to try and work with that team to be kind of like an automatic referral after chronic care management because they identify the people coming out of the hospital. So I think that's encouraging to be able to make that kind of progress. And based on our last month's information, I spoke about possibly having some lobby days, which is kind of different with CKD practices than it is with dialysis, but still think it kind of gets people interested in it, staff included, and kind of builds upon that. So we're looking at whether that can go forward or not. The other thing that we did that the doctors seemed to like was created a pocket guide with the sick P on it, and on the back side with billing information, and they seem to like that. Now I'll be checking tomorrow and Monday to see if more people used it or not and billed for it, but it was good to get that feedback that they liked that. So
that's very exciting.
There was discussion, although I don't know if Catalina's on the phone or not. She was still in clinic. Oh, you did. So, we're hopeful to think about asking Dr. Moss to come down this way as well. We have barbecue waiting.
Oh, I would love it.
Okay. Well, we're talking about you.
Okay, that's great.
Could you send us a copy of the card and we will get it posted on or you probably can do it yourself,
Sure.
but you just email it. We'll post it on the intranet, so people, I guess they would have to check the billing for their own practice.
Right. But it might give them an
example.
idea.
Yep.
Yeah.
Right. So
Sure.
Mary Beth, does the card have the Medicare billing codes for advanced care planning, the 99497 and 99498?
It does.
Yeah.
And it tells them how to do it in both of our systems.
Yeah. I think nephrologists like to hear that if they're going to spend 16 minutes, they can get reimbursed for it at a fairly reasonable reimbursement rate.
Yep. We thought that was a positive feedback too.
What a great
I'd be happy to. Yeah.
Great.
Now, who do I send it to, Dale? Do I send it to you, Glenda? Who do I make?
Anybody, anyone, anybody whose email you easily have, doesn't matter.
Got it. Okay.
Mary Beth, thank you so much for sharing that learning and those new ideas. One thing, when we were at Rogerson, they also have a CKD clinic, and they have something called the PAC program. And one of the things that the physicians identified was a desire with the Pathways project to really look at patients who progress onto dialysis, and that they feel like they want to really look at, are they exploring the medical management without dialysis option, as extensively as they would like with some of the patients. And so I'm sure that that's something that's really true for all of the CKD clinics. And so we'll be sharing more information about that as that site gets up and running. Also, Dr. Frumkin's practice is starting a PAC clinic that will be run out of their practice, I believe, and so we'll be able to learn some things from them as well.
Oh, that would be great.
Yeah. Okay. Anyone else have something that you want to share with us about any challenges you've had, any progress, successes? Well, okay. Steve, are you on the call, I hope? Steve Wise?
Yep, I'm here.
Hi, Steve. Would you share with us, or is it Josephine? I'm not sure who's going to share with us that case that we asked you to.
Yeah, Josephine's going to actually go over it. She's the clinician on it, and then I'll just kind of interject anything that needs to be added to it.
Okay, that's great. Thank you. Welcome, Josephine.
Hello, everyone.
Hi.
We had this patient, 89-year-old female patient, very sick patient on dialysis. She has been with us since 2016, but this past year her health has been really deteriorated. She has a history of diabetes, hypertension, CA colon, and breast CA. She had some heart issues where she had a pacemaker, but her health really deteriorated to the point where she was very hypotensive on the machine. Most of the time she would come in with a blood pressure of 60/20, where it was very difficult for us to initiate dialysis.
Oh, boy.
At first we used to give her fluids, stabilize her blood pressure, so we could even dialyze her, but she was also had a lot of fluid in her, and so we were just dialyzing her, couldn't even remove the fluid, so she was like in and out of the hospital for fluid overloaded because we couldn't, do any UF on her at all. But She had a healthcare proxy. It was her daughter, but she never wanted to stop dialysis, even though in the past they had that discussion with her. But no, she wanted to stop, but the family didn't want to stop. She always wanted to stop dialysis, but both the daughter and the son didn't think, they wanted the mother to stop dialysis because they knew once she stopped dialysis, it would be the end for the mother. And I guess they didn't want to come to terms with that, even though the patient wanted that. So, but to the point where toward the end, she was really deteriorating, and she kept verbalizing to the daughter, who was the healthcare proxy, that she wanted to stop. So at some point, the daughter came to us and discussed possibly to stop treatment. So in the past, we probably would have just referred her to the hospital, but since we studied that pathway program, and I had Steve as a backup person to discuss the case with, and he had told me we could refer her to a hospice partner of us, where we refer patients in the past, where he referred patients in the past. So he gave me this information. So we had contacted the hospice person, but I also informed the nephrologist, but the nephrologist wanted to go with the hospice that belongs to the hospital. So even though we had already contacted this particular hospice program, but then the patient's nephrologist had her own, hospice program in the hospital. So she wanted to take over. So she referred the patient to this particular hospice. But the main thing, she didn't have to go to the hospital. So we initiated the hospice from home. And it didn't take her too long to pass, but at least we were able to respect her wishes and the family wishes. I don't know if Steve has anything else to say.
No, I think that's a great summary. I think this is just, for me, it's a good example of how even if we're not doing direct conversations or goals of care conversations, this program has kind of propagated a little bit within our organization, where now we're making sure that we have a hospice partner. We're making sure that our clinical team is aware of what resources are available. Had a few other cases now, even in other non-Pathways units, where we're now reevaluating what do we do with patients who are DNRs who pass on the machine, and do we have a system that allows us to directly refer them out of the unit rather than going through the ER. So this is kind of propagated for us, and I think brought us to a different level of discussion that we didn't have before, which is nice. Josephine has another case that she's working on right now, actually, which maybe we'll talk about next month. A new patient who doesn't want to be on dialysis, and we're kind of working with the healthcare proxy on how to work through that. So it's very encouraging to hear these conversations going on.
Well, thank you. Thank you, Steve and Josephine, so much. And so the outcome for this patient was that, as you say, her wishes were respected, and she died peacefully at home and without a lot of family conflict. So a successful outcome. Great job, everybody. So Woody or Dale, would you like to make any comments?
I think this is the value of having conversations and learning patients' wishes. And Dale's going to be presenting data later that the vast majority of patients who've died in the Pathways Dialysis Center so far are dying in the hospital. But yet when you ask dialysis patients where do they want to die, the vast majority want to die outside the hospital. So I think maybe we're going to turn this around a little bit as we have more conversations.
Yeah, and I would just comment that this takes a very big shift in our own thinking about what a quote unquote good outcome is. And so to be able to say that there are ways in which a death can be a good, quote unquote, a good outcome or a good death. There are things that really matter to people at the end of their life, and the way that they experience the end of life can be either compounding their suffering and compounding their family suffering, or can become a much more peaceful sort of end of the story. So, we're not only about end of life, but this is a big piece of it. And so to hear you guys talking about being able to help, I do hear that you really changed, and this is something different than would have happened before. As you said, Josephine, you would have just referred them to the hospital. So that is amazing that this person got to avoid a hospitalization and got to have a peaceful time with their family. I think that's just amazing.
Right. Okay, thank you. And we look forward to hearing more cases from others. And also, Steve, yes, maybe next month we'll learn about the other cases going on.
Yeah. Linda, can you hear me?
Yes,
Yeah, I just want to, this is Lou Diamond. It just seems to me, thank you, that this last case that Josephine presented is incredibly reassuring, because, and we need to find a term for this, because this is like spread to an adjacent population. This patient wasn't part of the Pathways project, as I understand it. Is that correct?
No, she was one of, she's at the Boston Center. She was first ill.
Oh, I see. Okay.
She was. What I was saying is that the Pathways project, we've had other centers now where we're starting to have conversations and starting to look at policies and procedures as a result of the training and the work we're doing at the Pathways centers.
Yeah. So that's what I was getting at. It does seem to me that that's an important offshoot of the Pathways project, and the Pathways team needs to find a way of capturing that, because that's an important spread that is occurring. You can call it an adjacent spread, if you will, but it's very helpful and very, very reassuring.
Right. Okay, that's absolutely true. Thank you, Lou. Well, let's move on to the next slide. I'm keeping an eye on the time here. Woody, would you like to say some things about Ask Till Ask?
Yeah, so it's thanks to Mary Beth's input, and this is the way it works. We all gave each other ideas. I was just sending an email to Sherry with the billing code information, because physicians and nurse practitioners can bill for these conversations. So this is a card. This is the card that I passed out to clinicians at Rogerson, to the physicians, nurses, social workers, and it has the questions. And you heard Hillary refer to the fact that some of the questions are very, she hadn't thought about the fact that if the patient doesn't want to be on a breathing machine, then that patient really doesn't want CPR, because if the patient were to live through what we would call a code, invariably they're intubated as part of the airway management, as part of CPR. So this, on the second page in the tell portion there, sort of walks them through that. And even, the last bullet right before the second ask is CPR is not as successful as most people think. Would you want those treating you to attempt CPR if your heart stopped? If you live through CPR, you will be on a breathing machine. Is that what you would want? And for these patients that I talked to at the Rogerson Manhattan Dialysis Center, they really did not want to be on a breathing machine. And I think Hillary was reflecting the fact that the first woman I spoke to hadn't thought of it that way. And then when I put it in that context, she said, well, then no, I definitely don't want CPR. So these are questions. I think we're going to be mailing everyone on this call and everybody on your team a copy of this card. I'm just thinking that I'm going to try and figure out a way to put the Medicare billing information on this, because you can definitely bill for these advanced care planning conversations. And you can do it while they're on dialysis. You just need to use a modifier. So you just have to talk to your billing and coding person, and it's like a G25 modifier. It's one of the modifiers that they'll know about. So that's all I want to say. Thanks.
Okay. Thank you, Woody. Next slide, please. So I'm not going to spend a lot of time on this, but I just wanted to talk for a couple of minutes on small tests of change. You know, as professionals, we have a tendency to say, oh, we need to change something, and so let's just, write a policy, or let's just tell everybody that we're going to do this procedure differently, and then, bam, we wave a magic wand and think it's going to happen, but that's really not the way change happens. And we all have our aims that we developed for the Pathways project, and I think that as you go along in the project, you're developing smaller aims. Like, for instance, Dr. Berman voiced an aim when we were there to get the most forms on the 100% of his seriously ill patients. And so when you want to make a change then, obviously you want to make sure that it's going to be an improvement, because not all change is an improvement. Next slide, please. And remember, we talked about the Plan, Do, Study, Act process when we were in D.C., planning how to test a change, taking into account organizational and cultural differences, actually trying a change in a small way and tracking progress and measuring. And the study part is so important to really look for any insights you have on what did you learn and how to do it better. And then acting is actually making the successful changes permanent, or maybe you learned something and you need to do another test and even more tests. So why should you just do some tests? It increases your belief that the change will result in an improvement. It helps you decide maybe which of several proposed changes will lead to the desired improvement. If you go in and make a bunch of changes all at once, maybe you get the outcome, but you're not sure exactly what caused the change. Evaluating how much improvement can be expected from a change. You may make some improvements in some areas with one change, but it might take 4 or 5 or 6 changes to actually achieve the overall aim. Deciding whether the proposed change will work for the actual environment that you're in. Some things just don't work there, culturally or whatever. And then finally deciding which combinations of changes will have the desired effects on your important measures that you're. And finally, one that's really important is minimizing resistance upon implementation. If you test something out several times and you have a team involved and they study it and they come up with an improvement and you can show that it's an improvement, it really helps to overcome any resistance to change that might happen as you roll out a facility-wide change. Next slide, please. So, again, here are some small tests that certainly fit into our aims in the Pathway Project about when we might look for advanced care planning and goals of care conversations, admission, changes in health status, post-hospitalization, move to rehab or long-term care, and other changes. Next slide, please. So we talked about this, planning and doing, convening the team. Again, on this study question, what was learned? Barriers and challenges, workarounds, failures, what didn't work? Because a lot of times when we try something new, it doesn't work the way we thought it would, do we? Does it? And we want to understand from that and learn from that before we make a facility-wide change. And, of course, any unintended consequences. Next slide, please. This is just one little schematic showing, let's say you decided to conduct goals of care conversations within 30 days. And you say, okay, we'll test this on the next 2 patients post-hospitalization within 30 days of hospitalization. And so you go out and you do this on 2 patients and you come back and you gather some data. How long did it actually take you to get this done between hospitalization, discharge, and goals of care conversations? Did you actually get to do it? And who held it? And was it documented in the chart? And convene the team and come back and discuss the results. How did the conversations go? What was learned? Apply that learning and then go out and do another 3 to 4, rather than saying, okay, we're going to do, the whole facility in the next 30 days or 60 days or even 6 months. Start small, try it out, see what you learn from it. Next slide, please. Or maybe you decide to have goals of care conversations within 10 days of someone being identified as seriously ill. You might do the next 5 patients. Each team member might do one. We have our social workers, our nurse practitioners, our physicians, all are learning the skills and are certainly empowered to have these conversations. So everyone needs to be out there practicing. So maybe each member of the team, of your change team, does one conversation, or you do 2 in the next week as your goal. And again, you're gathering data. Did you get the prognostication done, and was that discussed? Was the actual goals of care conversation held? Who held it? Who attended it? Was it documented? And finally, convening the team again, discussing your results, learning from that. How did it go? What was learned? Maybe you couldn't get the family to the meeting, and you really need that. And so maybe your next small test of change is to set up and test how you would conduct a Zoom meeting, including a distant family member. Next slide, please. So that's it for me on the small test of change. I am here to help you design and test these. If you will reach out to me, and as I have my monthly calls with you, I'll be following up on some of these ideas that we've talked about. And now I am going to turn it over to Dale, I believe.
Yes. Hi, thanks. And just one thing I just want to remind people about small test of change. It really does help overcome resistance to say to people, we're just piloting. We're just going to pilot this with 2 people or on 1 shift or something. It really overcomes people's resistance to trying something new. So it's a good technique that way. So just a reminder that this is kind of the whole process, that when you did the advanced care planning chart audit, this is what these are all the things you're looking for, and we have it arrayed in this nice continuum, but of course some pieces of this could happen. It doesn't have to happen just in this way, but so for instance, we'll look at data. Let's go to the next slide. So now I want to look at the data where we are in the process. So the staff survey, the Kidney Supportive Care Implementation Quotient Survey is done, and I'm getting a report out to you where you can see what sort of as a group, what you think is the areas where you're doing well and where you need most improvement. Everyone has done the death audit of the 5 recent deaths, and as we heard Mary Beth report on theirs, it sounds like that's been a pretty big sort of learning for groups to just take a look and see how that's going. The May monthly report, everybody managed to get a report in. Thank you. I know that first one was it was more painful than we expected. Thank you everyone for the work that went into it. And I'm going to report, you've seen the report, but I'm going to go over a couple highlights in a minute. And now what's in process now, people are working on their June reports, both the facility and the one that gives us the monthly data on the seriously ill patients. Some of you are done with the chart audit for advanced care planning. Some of you still have that in process. And we're still in the process of approaching the patients to be interviewed. And one of the things we want to report there is, even though you've approached them and asked them, they seem to not remember it, of course. So we're mailing out a postcard. We'll show that to you later. But anything you can do to help remind them that they're going to get this call from this strange West Virginia number, and we really do hope they'll pick up. And then what's up next is the July monthly report on the facility, on the seriously ill patient demographics. And then this big bolus of data collection tapers off. And what you do for the next months after summer, the next 18 months, is you really only have to do the facility report each month, and then your own small data collection for tests of change, but that's not a big formal thing, and you don't necessarily report that to us. Next slide.
Dale, we're actually going to give them time to talk to their patients, which is the whole goal of this project, right?
Exactly. So here's a big success for everyone. So if you remember when we first started, this whole idea of you're going to identify seriously ill patients was like, how are we going to do that? What is that? Why are we doing it? And even though we see number 10 here, it looks like they didn't screen everyone. They did, and this is a data. We're waiting for somebody to come back from vacation until we can correct the data. Number 10 actually did screen all or most of their patients. So overall, over all the sites, we have we screened 18% of patients came in as seriously ill. You can see there's some variation. The site that's at 45% makes a lot of sense to us based on our discussions with the site. That's a site that has a lot of very sick patients, a lot of nursing home patients. The site number 1, that's 5%, we think that may change a little, that they may have been screening a little too tightly. But overall, what we're hearing is, yeah, like identifying that these are the patients who we better talk to soon has been helpful. So that's success number 1. Let's go to the next slide. Now, the next thing that we're going to be tracking is something that we hope over the course of this project that we'll see you using more is palliative dialysis. And already in the first month of reporting, we had 2 centers who reported that they had, one center reports 1 patient with palliative dialysis and 1 center reports 2. So this is an area we haven't talked about a lot. We'll talk about it more during learning session 2, and as we sort of are doing our consultations with you, it may come up that this is a good option for patients. The other thing when we were with Rogosin that we talked about a lot and that we are not tracking specifically is time-limited trials of dialysis, but I would put that in this. So we didn't determine that we were going to track that, but I would hope that we'll begin to see more use of palliative dialysis. And of course, the question of how do you schedule it, how does it impact your quality measures, those are concerns that people have. And so these are the kinds of things where if you do a small test, like this is 1 patient we're going to try it with, that's a small test of change here. Okay, next. So looking at deaths, again, I want to emphasize this project is not only about deaths, it's about keeping people comfortable and meeting their needs while they live. But death, the end, kind of what I call the end of the story, is very important for people and very important for their families. So overall, we had 63% of deaths took place in the hospital in the May report, and 7 patients were admitted to hospice. Now, the patients admitted to hospice may not be exactly the patients who died, but I'm putting it on this slide. So we think that this 63% hospital deaths is something that we hope to see move quite a bit over the course of the project. And as we heard from Josephine and Steve from Atlantic, they already changed their practice in a way that definitely impacted 1 patient in that way. So I do think this is something that's we're likely to be able to see in the data over the course of the next year and a half. Next slide. And now this is the baseline chart audit. So not everyone has submitted their data here yet, but just to look at the variation that we see from the five sites that we have here, the lighter green is that there was no information on whether the surrogate had been named in the chart. So you can see, and then the red, the dark red, is that the name and contact information are recorded in the chart. So you can see that there's quite a bit of variation across sites here as to how well they're doing it, or how consistently they're doing it. And as we've been talking with folks, it sounds like this is more a process question, just like knowing where to put it and just everybody determining this is something you're going to do and it's going to make it into the chart in some way. Let's go to the next slide. And then we've measured many points in your chart audit around this whole process by just showing you a couple. So then skipping to the baseline, whether there are medical orders, so DNR, MOLST, or POLST in the chart. And again, you can see that the dark green is yes, the DNR, MOLST, or POLST was in the chart, and the light blue is no such thing in the chart. And again, this seems to be quite different. And when we talked with Rogerson, this wasn't even something that was part of the thinking. It was not even part of the normal process. So they're beginning to investigate how they can do it, where they would put it, who's going to enter it, how would they, and then let's go to the next slide. I believe there's one more. Oh, no, okay. So then the next thing that you are reporting to us is whether those MOLST or POLST got entered into a registry. And whether it's in a registry, if there's a registry available, of course, that helps to make it, if everyone's using the registry, it helps to make it available across settings. But you might also determine that there are other ways. So, for instance, Rogerson is just going to try to get those MOLST into the hospital record for the hospital where about 80% of their patients go. So that might not show up as a registry when we count it, but it would be a good change on their part. So those are just some of the highlights from the data, and we're going to keep sending you little snippets. You are free to share the data as you talk with staff. If you want us to produce any kind of special compilation for you, or slides, or look at it in a different way, I know Kim, our data analyst, is a whiz at creating those charts, and we'd be happy to do that for you, because I think that showing people the data, like here's where we are, let's say just 66% hospital deaths, and we want to change that. It's helpful for people to see the data. I think in making change, there are two things that help. The data helps, the objective data helps, and the stories from patients and patient care help. Both of those things are part of helping people get motivated and change. So that's what I have to say about data for now.
Thank you, Dale. Well, it's going to be more and more interesting and exciting as the project goes on, as we build on this data, and look forward to seeing the positive changes as the project rolls out. So key activities, we've been looking at this every month. You can see that we've got quite a bit of this really accomplished, and we're pretty much moving on to the monthly submission of the data and our monthly conference calls. For those who haven't finished your advanced care planning chart audit, we encourage you to do that. And if you have some barriers or challenges with that, please reach out to Kim or I and let us see if we have a way to help you overcome that. And looking at the future, individualized consulting, of course, we've mentioned this. Please email if you want to set up a time for us to come visit you. And the dinners with Dr. Moss or lunches, whatever works. And finally, communication training for all your staff. We encourage you definitely to make sure that all of the staff at your unit, even down to every technician, and understand that the project is a part of what you're doing there, and give them an understanding. Amanda made a wonderful short little video that gives a great overview of the project. It's just perfect to show to all staff. And it's quick, and it can be done in several different settings. So we encourage you to do that. And then we do communication for all staff. And we'll be talking more about communication training in the future. Next slide, please. All right, here we have some reminders. Sherry, do you want to say anything about this?
So Peyton Smith just joined us. He's a recent graduate of the University of Nevada, Reno, and he'll be attending GW in the fall in the public health program. Over to
Wonderful. You. So the postcard reminders have been sent to patients that agreed for interview.
Yeah, can I, Glenda, can I just say the patients have told our nurse interviewer that they don't recall being told about the study. I find this hard to believe, and that they didn't realize somebody was going to be calling them. So this postcard that you're looking at on this slide, we're mailing to them, but I'm wondering if it would help if we sent your dialysis centers or your CKD clinics some of these postcards so that you could actually give one to each patient, sort of as a reminder that somebody is going to be calling them from a 304 area code to interview them. We're trying to interview a bunch of patients from Auburndale and Ridgewood right now, the dialysis center, some of the dialysis centers in New York, and the comment is nobody is answering their phone, even though we're calling on off dialysis days. So our suspicion is they probably have caller ID and they just see that it's a strange number. So, if you could email, anybody, Peyton's email address or Sherry's or mine, anybody, just let us know if you think it would help if we sent you, these postcards so that you can hand them to the patient, and then I think we'll still mail them to them so that, they get something the day, you first talk to them about it, to get something else in the mail a week later. But we really would like to have a fair number of patient interviews, and right now only about a third of the patients that have told you, yes, I would agree to be interviewed, are we actually completing an interview on, because either they're not answering the phone, or when they're called and they answer the phone, they say, oh, I don't know anything about that, and they hang up. This has really been a problem for us, if you can help us.
Okay, thanks, Woody. So we obviously have our resources unboxed. If you need any assistance with that, contact Amanda. Hopefully you're looking at the newsletters. We're putting thought into this and hoping to provide useful information for you. We haven't had much activity on the listserv, but we hope to get that kind of going. And our next monthly call is on August the 22nd, and then our learning session to October the 24th and the 25th. Thank you so much. We appreciate all of you and what you're doing for your patients, and we look forward to the month ahead. Reach out to any of us if you need assistance.
Thank you,
Bye
guys.
now.
Yeah.
Bye.
Thank you very much.